Pathology of posterior urethritis. The pathologic changes produced by gonorrhea in the posterior urethra are essentially the same as those produced in the anterior urethra, but certain anatomical differences vary the actual conditions. These are, in the membranous urethra, the relative rarity of glands. In the prostatic urethra, the complexity of the glands immediately beneath the mucous membrane. The verumontanum, the great complexity of the internal sexual glands, prostate, vesicles, emptying into the posterior urethra. In the trigone, the rarity and simplicity of glands. We must therefore describe gonorrhea of 1. The membranous urethra, 2. The prostatic urethra and verumontanum, 3. The prostate, 4. The seminal vesicles, 5. The trigone, 6. The vas and epididymis. The membranous urethra. The glands of the membranous urethra are relatively few and simple. Hence, chronic gonorrhea of the membranous urethra is clinically mild and is overshadowed by the inflammation of other portions of the canals. Submucous infiltrates are usually slight. Stricture is rare. Chronic glandular catarrh, usually mild. The prostatic urethra. The relatively large and complex glands in the mucous membrane of the posterior urethra, page 281, and the sinus pocularis of the verumontanum form nest for possible abscess formation during acute gonorrhea of the posterior urethra, and even after the acute general inflammation has passed. These abscesses are larger than those commonly formed in the glands of the anterior urethra. They excite fever and burst into the canal with a recognizable outpouring of pus. Chronic posterior urethritis. The urethral mucosa undergoes much the same change as those of chronic anterior urethritis. But as the inflammation grows less, it may become localized in certain special forms as follows. Velocities, improperly termed papillomata, may persist in various parts of the posterior urethra. They are exuberant granulations arising from a small ulcer. Follicular abscesses and cysts are rare. They usually occur beyond the verumontanum. Verumontanitis. The verumontanum may be regarded pathologically as a hood covering the prostatic utricle. Hence, a chronically inflamed verumontanum is always associated with utriculitis, usually with vesiculitis. The urethroskop shows a swollen red verumontanum, perhaps much hypertrophied and covered with granulations. Irrigation of the utricle usually discloses pus in its cavity. Amputation of the verumontanum, rhytina, shows submucous and periacinous round cell infiltration. Stricture at the bladder neck or throughout the prostatic urethra is rare. It is attributable to chronic sclerotic prostatitis, page 285. The prostate. The prostate is implicated in almost every inflammation of the posterior urethra. Prostatitis is by far the most important complication of genital gonorrhea in the male. It is frequent, it is intractable, it is the source of many grave lesions within the prostate itself, and is a port of entry for systemic gonorrhea. Whereas the glandular lesions of the anterior urethra are almost exclusively due to gonorrhea, the prostate may be, and often is, inflamed by other bacteria. 3 types of prostatitis are recognized: the catarrhal, the follicular, and the parenchymatous. The distinction is a clinical rather than a pathological one. In the prostate, as in the less complex glands of the anterior urethra, the inflammation is a suppuration within the gland associated with more or less surrounding infiltration, which infiltration may terminate in sclerosis or in suppuration. Catarrhal prostatitis. The inflammation extends into the prostatic ducts, but spares or does not markedly involve the acini. The inflamed ducts are dilated, filled with pus and debris. The surrounding stroma is but little infiltrated. The examining finger detects no change in the gland but can squeeze pus from it. The diagnosis is not made until the acute posterior urethritis has subsided, leaving the chronic catarrhal prostatic lesion. Follicular prostatitis. The inflammation reaches the acini, which are distended with pus, while the surrounding stroma is infiltrated. In the acute stage, the prostate is congested, tense, sensitive. As the inflammation becomes chronic, the general congestion disappears, leaving the gland lumpy to the touch. The lumps are constituted by areas of diseased acini, suppurating, cystic, necrotic, or atrophic in an indurated stroma. Parenchymatous prostatitis. The follicular involvement is more intense, the interstitial inflammation more widespread and intense. Abscess of the prostate results. The suppuration occurs in small, multiple foci, few or many, which may resolve without rupture or coalesce to form a large prostatic abscess and rupture into the urethra or into the ischiorectal fossa or rectum. Chronic prostatitis, macroscopic changes. To the examining finger, the chronically inflamed prostate may show no change. More commonly, it is enlarged. This enlargement consists of a general bulging of one or both lateral lobes or the presence of masses of induration in or about the gland. The general enlargement of a lobe may be tense and irreducible by pressure, or it may soon yield to massage, leaving in its place a sunken pit surrounded by a more or less clearly marked rim of induration. With the subsidence of a swollen lobe under massage, there is an outpouring of purulent prostatic secretion from the meatus. The indurations may be prostatic or periprostatic. They are irreducible by massage, but usually diminish in size or disappear after repeated massaging or even, in time, without massaging. Microscopic changes. Periacinous infiltration is so invariably present that we may speak of it as the essential lesion of chronic prostatitis. Sometimes it is combined with more extensive interstitial and endoglandular processes, but not infrequently in extensive areas, the periacinous lesions may be present alone. The changes in the acini are manifold. In some instances, the cul-de-sacs are dilated. This dilatation may be due to stricture or obstruction in the excretory ducts, but is probably more often the result of an accumulation of inflammatory products in the glandular sacs, the muscular tone of whose walls has been injured by the inflammatory process. Acini, however, the caliber of whose lumina is diminished, are almost as frequently seen as are dilated ones, and this is especially true where the prostatitis is of long-standing and an extensive periacinous sclerosis has formed. At times, the acini are mere vestiges or may even be entirely replaced by fibrous tissue in areas of considerable extent. The acini are often partially or entirely filled with proliferating and desquamated epithelium. These lesions are unevenly distributed about the gland. Areas, large or small, of normal gland are usually present, and in some instances, the diseased area is confined to that part of the gland adjacent to the urethra. The dilatation of the acini may be very considerable. This dilatation is the foundation for Czekanowski's theory of the inflammatory origin of prostatism. Changes in the secretion. The normal prostatic fluid is an opalescent fluid, alkaline to litmus, and acid to phenolphthalein, whence the arguments as to its reaction. As obtained by massage, it usually contains gelatinous, transparent masses of vesicular secretion. The pure, normal prostatic secretion is filled with minute lecithin bodies. It contains a moderate number of columnar and round epithelia. The nuclei of the latter almost fill the cell body, a very few leukocytes, a few corpora amylaceae, and perhaps red blood cells from the trauma of massage. The abnormal prostatic secretion is purulent. It is not so opalescent as the normal secretion. When mingled with urine, passed after massage, it often looks granular and flaky to the experienced eye. There often settles at the bottom of the glass a deposit of crumb-like purulent masses, shreds. The normal elements are in inverse proportion to the amount of pus. The reaction, like that of the normal secretion, is acid or alkaline according to the reagent employed. Bacteria are sometimes present in great numbers. In rare instances, pus is only obtained after the second or third massage, the secretion expressed by the first manipulation being exclusively from the normal portions of the gland. The diagnosis of pus in the prostatic secretion should always be confirmed by the microscope. Seminal vesicles. Seminal vesiculitis. The acute changes caused by gonorrhea of the seminal vesicle are similar to those in the prostate, with this exception, that the vesicle is a gland of so much larger caliber and with so much larger a duct that recognized abscess in it is uncommon, and its parenchymatous changes, if unaccompanied by dilatation, are often clinically overlooked. Chronic vesiculitis. The normal vesicle is impalpable unless greatly distended with semen, yet the vesicle, like the prostate, may be inflamed, though apparently normal to rectal touch. The walls of the vesicle are infiltrated and matted together in what is pathologically a perivesiculitis. This may or may not result in a palpable enlargement of the gland. The mucosa is infiltrated and eroded. The lumen is in places contracted or occluded by stricture, in others dilated. This general dilatation can always be demonstrated by injection of argyrol into the vas. In long-standing cases, the vesicle may be changed from its normal state, a branching, ramifying canal, to an irregular cavity containing several cc's of pus. Chronically inflamed vesicles have been appropriately termed by Belfield, quote, pus tubes in the male, end quote. Vesiculitis is always bilateral, often impalpable. Secretion. The secretion of the normal vesicle varies in consistency from thick gelatinous to sticky and ropey. The microscope shows mucoidal masses entangling spermatozoa, sympexia, and epithelial cells. The color is usually opalescent, but may be rusty, especially in older persons, from pigmentation of the contained epithelia. When spermatozoa are absent, Böttcher's crystals are usually found. The vesicular secretion floats, in part, in water, whereas the prostatic secretion sinks. The secretion of an inflamed vesicle contains pus and bacteria. Live spermatozoa are sometimes, though not often, found in purulent vesicular secretion.